Yeah, sure, sir. Thank you, sir.
And that all of you know Dr. Ajay has joined as a professor. And please, Dr. Ajay, introduce our today's speaker.
Yeah. Shall I start, sir, or one? Shall I start, sir?
Yeah, can sir, but
Yeah,
I
yeah.
can still feel some
You start
voice
with the introduction.
pickup is there.
Yeah.
Never mind, never mind.
Because of network issue.
Okay.
नहीं उनको भी
Hello, Bhumika.
Okay, Bhumika, you can start now. Bhumika. Okay, I will start. Welcome all the delegates and our speaker, Dr. Neeraj Kumar Fuloria, on the third morning session of third day of 25th QIP. Morning session of third day of, and this session is chaired by our Professor Ajay Sharma, Professor in Prognosis Department, and he has a vast experience in his teaching as well as in research. Dr. Ajay, it's not clear?
Yeah, I am okay, ma'am.
No, my voice is clear?
Yeah. It's clear, ma'am.
Okay. So I request Dr. Ajay Sharma to introduce our speaker, Dr. Neeraj Fuloria.
Okay. Thank you very much, ma'am. Yeah,
I'm
thank you very much.
Slide.
Yeah. On the behalf of DIPSAR and DIPSRU family, I, Professor Ajay Sharma, welcome you all who are presented over here. And it's my pleasure to introduce Dr. Neeraj Fuloria. He is one of my very good friend. Both of us has been associated with one of the common organization or society. So it's my pleasure to introduce Dr. Neeraj Fuloria, the speaker of the first session of this 35th QIP program. Dr. Neeraj Fuloria is working as an associate professor at Pharmaceutical Chemistry Unit, Faculty of Pharmacy, AIMST University, Malaysia, and Managing Director, Alethea Life Sciences. Dr. Fuloria got his pharmacy degree from Gulbarga University, Karnataka in 1993. He did his master's degree in pharmacy in the year 2003 from RGUHS and MBA in 2004 from Madurai Kamraj University and PhD in the year 2010 from GBTU University, Uttar Pradesh. He has total work experience of more than 19 years in different capacities in academic research as well as in industries. He has published 80 research papers and review articles in journals of national and international review. He has also published 3 mock courses. He supervised 6 PhD and 5 M.Pharma students. He received Young Achiever Award, Appreciation Award during Teachers Award ceremony of Kedah State University, Malaysia at AIMST University. He received Best Presentation Award at 19th International Conference on Medicinal Chemistry and Molecular Pharmacology, March 2017, Singapore. He received Research Fund under Ministry of Higher Education from Malaysia, received National FRGS grant from Malaysia, Greater Research Network System, that is migrants, under Ministry of Higher Education Malaysia, International Grant for Tubulin Innovation Studies in 2018. He has also received grant from AIMST University Malaysia for 2 years. Now I request Dr. Neeraj Fuloria to share his views on orthomolecular medicine and enlighten all of us by his kind words. Over to you, sir.
Thank you, sir. Thank you, Dr. Ajay. Thank you for such a nice introduction. Just one correction. Actually, I am senior associate professor here, so it's okay. Never mind. Wish you all a very good morning, good afternoon, and good evening to the organizing committee members, contributors, and participants from India and all the corners of the world. Firstly, I would like to congratulate the Professor R.K. Goyal, the Vice Chancellor at DIPSRU, and the organizing team of DIPSAR to successfully organize this 35th QIP event. I am also thankful to the organizer of this event to give me the opportunity to share my views for this today's session, that's orthomolecular medicine. So moving on to my presentation title, that is orthomolecular medicine. So let me share my screen. Can you enable me the screen sharing, sir?
Screen sharing.
Yeah.
Manju madam, screen sharing.
Sir, you start sharing.
Yeah, madam, but you have to enable me first.
Okay.
Because I am disabled right now.
Okay.
Kindly enable.
हो गया sir, हो गया. Now you can start.
Okay, madam. Thanks. So let me make it full screen. Okay, I'll use my pointer.
Yeah, it came, sir.
Okay, sir.
Yeah.
So moving on to my presentation title, that's orthomolecular medicine. It's a traditional and complementary medicine approach. So what is orthomolecular medicine? Many of us get confused normally. Orthomolecular medicine means something related to bone. Today, my father was also asking me, hey, what's your title? I said, it's orthomolecular medicine. He told, that means it's to bone. I said, no, it's not bone. So just sharing with all, because definitely who are from the traditional system, they must be knowing about this. Other members, just a short meaning. In Greek, ortho means right or correct. So orthomolecules is giving a right or correct molecules that is required for body. This concept of orthomolecular medicine, this idea was conceptualized by double Nobel laureate Linus Pauling. This orthomolecular medicine is aimed to restore the optimum environment of our body in a healthy condition state, like with the biomolecules, what is in our body. So how does it act? Orthomolecular medicine acts by correcting the imbalances or deficiencies based on any individual's biochemistry requirement of body. So it uses the substance that are natural to the body. So that is the orthomolecular medicine. Some examples in form of orthomolecular medicine molecules are vitamins, amino acids, hormones, metabolic intermediates, and minerals. We all can call these as orthomolecules because all these are required in our body and these are natural to our body. So what is orthomolecular medicine? Basically, it has been categorized as a complementary and alternative medicine branch that has been designed by National Center for Complementary Alternative Medicine. Now it is called as National Center for Complementary and Integrative Health. So there are 5 domains. One is alternative medical system, mind-body intervention, biological-based therapies, manipulative and body-based method, and energy therapies. Of this, this orthomolecular medicine falls under the category of biological-based therapies. So the history of orthomolecular medicine is very near. It initiated from the early 20th century, wherein the doctors used to postulate that vitamins could cure disease. From there, the idea came. In 1930, the vitamins were prescribed as supplements in megadose. In a higher dose, they used to prescribe the normal dose. McCormick postulated vitamin C in 1948 to cause many disease and was used in large dose in patients. So deficiency of vitamin C in 1948 was postulated as to cause the many diseases. So that's why they used to give this vitamin C in very large dose. So that's why sometimes they call it as a mega vitamin or mega nutrition or mega dose therapy. In 1949, Gerson, now who is called as an orthomolecularist, developed a diet to treat these diseases. Later in 1950, it was believed vitamin deficiency causes mental illness. So that's why in mental, the brain-related disorder, the use of this orthomolecular medicine is very common. In 1950, Klenner used vitamin C in megadose to treat various illness that included polio also. In 50s and 60s time, nutrition was not very much emphasized in the standard medical curriculum. So Irwin at that time stated that organism unable to produce own vitamin C possess hypoascorbemia disease. Later, Osmond and Hoffer also used the high dose of niacin in acute schizophrenia. This was during the phase of 1950s and 60s. So later on, niacin with the other statins was became an important therapy for the treatment of CVD. Then later in 1960s, at the end, in 1968, Linus Pauling introduced the word orthomolecules. First time it was being used to express the idea of right molecules in right amount. And this concept was introduced for the prevention and treatment of diseases in 1968. So it was a radicalized research when he published a paper in 1968 based on the orthomolecular psychiatry. So there the radicalization happened and this concept was in front of the whole world. This was the history about orthomolecular medicine. It's very recent, around 100 years previous only. So coming to the OM concept, orthomolecular concept. So it rests on the concept of bio-individuality. That is, there is no one size that fits to all diet. Each person has got a unique and individual nutritional requirement. Any difference in the anatomy, metabolism, or body composition may influence the overall health. True. Earlier, you see the blood glucose level, what we were saying, the normal was different. Now, as per the individually, they have increased the blood glucose level, also the normal threshold level. There's no single way of eating works for everyone. For you, it may be different. For me, it may be different. Food perfect for one's body, age, and lifestyle may make the other person get vain and lethargy. Like me, if you talk about, if I want to wake up for long, I need more food. I eat very heavy diet by 5:30 evening. So I can sit for long until night, 2 o'clock, 3 o'clock, whatever you say daily. So orthomolecular medicine is based on a belief that a disease in human body can be prevented by increasing or decreasing the concentration of naturally occurring molecules or biomolecules in our body, like vitamins, amino acid, hormones, metabolic intermediate, etc. We can manage our body illness by controlling the level of, adjusting the level of concentration of these molecules, biomolecules. Like phenylketonuria can be managed by reducing high level of phenylalanine rich diet. Seizures that depend on vitamin B6 can be managed by administering the vitamin B6 in large quantity. Administration of insulin injection in type 1 diabetes is the biggest example for this orthomolecular medicine. Insulin, what we use, that is once upon a time, it was under the orthomolecular medicine. Now it's in the mainstream conventional medical system now. So what is the rationale behind orthomolecular treatment? It varies from case to case. In OM therapy, selection of nutrient is done empirically. So wherein the optimal dose is not known. For some cases, OM act as replacement therapy also, like in case of scurvy. The vitamin C is a replacement therapy. So in few cases, the nutrition dose is beyond the normal need required. Among all physicians, only few practices OM as primary treatment. Otherwise, they take it as a complementary system together with our mainstream. However, gradual increase in documentation over the natural substances, now it is arousing the physician interest now. So as per Hoffer, the primitive people do not consume the processed food and do not have the degenerative. Based on our today's, whatever the food we consume, that also is a source of major diseases. Western diets are insufficient for long-term health. So that's why nowadays you see they eat a lot of roughage, you know. This demand for supplementation of megadose of vitamins, mineral, protein, antioxidant, amino acids, and many more, just to correct the metabolic anomalies at early stage before they may cause disease. So OM provides, this orthomolecular medicine provides prescription for optimal amount of micronutrients after individual diagnosis. So it depends. There's no standard format like here in when we go for our conventional system, paracetamol 250 or 500 or likewise whatever. But here it is as per the body requirement, we titrate the dose. Lifestyle and diet changes may also be recommended. The battery is ordered, includes many that are not considered useful by medicine. So coming to the evidences for orthomolecular medicine. So young adult prisoners, when administered with one multivitamin pill and 2 essential fatty acid supplements, they were less violent. This was a report given. 25 mg of zinc given to the people on antidepressant helped to reduce their depression more than the antidepressant alone. Nutritional deficiency affect brain function in very developmental stage of life. So that was by Dr. Fernando Gomez Pinilla. Now there's a myth about taking too much vitamins. In past 4 decades, handful of alleged deaths from vitamins versus hundreds of thousands of deaths from prescription drugs were been reported. For decades, Dr. Abraham Hoffer asked his students to provide
Sir, you got muted. Neeraj, hello.
Dr. Neeraj?
You got yourself muted.
Dr. Neeraj, kindly unmute yourself.
Okay. Am I audible now? Sorry.
Yeah. Yes, sir.
Okay. Maybe I'm using the mouse for highlighting, so that's why it has pressed the button.
Yeah.
So Dr. Abraham Hoffer treated 10,000 schizophrenic patients in his life, of which 75% of them were recovered. Depression, the major problem today. There are several causes for the depression, like your normal in our daily life stress, death of any near one, disability. There are some biochemical factors involved like imbalance in neurotransmitter, serotonin, norepinephrine, physical factors, then some medication that also leads to a side effect as a depression. Then overactive immune system that also leads to depression. Some genetic factors. It occurs at a higher rate in families where either a grandparent or a parent has a depression. Personality traits like anxiety and neuroticism, strongly these have been correlated with depression. Other sources are also that causes depression are toxic metal buildup and blah blah, so many. Then the major cause, which is in our Indians, it's a very common thing, sugar, the major principle. Overconsumption of sugar and processed food exacerbate depression, especially the white bread, pastries, breakfast cereal, crackers, cake, cookies. All these leaches the nutrients from the body, removes the protein from the body, leads to the negative moods ultimately and depression. So there are some treatment for that with the orthomolecule. They call it as a vitamin A. That has got an indirect impact on the depression because it acts as a cofactor in the metabolism of essential fatty acid. Thereby, it inhibits your depression. It cannot be completely inhibited, but yes, it's a complementary. We take it as. Then vitamin B. Many of the vitamin Bs are critical for both mood and energy regulation, like B1, B3, B6, B9, B12. Refined sugar and carbohydrates, alcohol deplete the vitamin B stores normally. Wherein the B6 increases the mood of women on the pill. So it corrects a deficiency word of sadness, irritability, and fatigue. These are crucial for hormone secretion, neurotransmitter production, nerve transmission, cellular metabolism, preventing damage from cortisol. Similarly, Dr. Gabriel Counsin, he prescribed B complex vitamin have more dramatic mood elevating effects than other nutrients. Similarly, this thiamine B1 psychiatric patient admitted to hospital have abnormally low thiamine level in blood that was been noticed. Talking about B2 improves the energy production in brain cells. B3 regulates the blood sugar, so thereby it further controls. So crucial component of another B complex vitamin NADH, which has prominent antidepressant effects. Similarly, B5 also exerts its effect. Pyridoxine also a most dramatic mood elevating effect. Correct brain metabolism dysfunctioning that causes depression. Similarly, vitamin B12, that is under 500 picogram it was given. So necessary for myelin sheath that insulate the nerve fiber, allows the free flow of neurotransmitters. Similarly, inositol has also been reported to show the beneficial effect to treat depression, panic disorder, attention deficit disorder, obsessive compulsive disorder. So according to Cousin, inositol lifts depression in 5% of patients. Choline, involved in the synthesis of release of neurotransmitter. When neurons are deprived of it, it may result in memory loss. So all these reports are there. Similarly, vitamin C, an antioxidant, we all know it, anti-inflammatory agent. So it was reported that 95% of clients with the depression required additional vitamin C. So with the Hug Riordan, every medical textbook until few years ago indicated that one of the most common effect of inadequate vitamin C was depression. Vitamin D, the patients suffering from seasonal affective disorder have been found to be low in vitamin. These are the reports. Vitamin E, we know, protects the neuron from the free radical damage. Low level of vitamin E can quickly limit the serotonin activity. It assists in slowing the Alzheimer's. So essential fatty acids acts low blood level of EFA have been associated with depression. Similarly, this E3 live that is called as a 100% EFA, that's aphanizomenon floss aquae, invisible flower of the water is called as, it is considered as nature's most beneficial superfood. So it's wild harvested from upper Klamath Lake, Oregon, and the highest concentration of chlorophyll and protein, 22 amino acid, includes 8 essential. So it is a natural mood elevator and antidepressant. Contains a complete balance of vitamin except for vitamin D and E. So according to Dr. Brian Clement, reports suggest within an hour of taking E3 Live, suicidal thoughts even went away for the first time in months. It provides 64 easily absorbed vitamins, mineral, enzyme, as well as providing antioxidant and valuable proteins. So Gabriel Cousin, they prescribed E3 Live, and E3 Brain-On offers specific benefit to the nervous system and brain function. Because E3 Live gets to the root of helping heal the addictive brain chemistry that underlies a lot of depression. Similarly, if you see the chlorophyll structure here and this iron, the structure is almost similar, only the difference is in magnesium at the core. So thereby it enhances the overall well-being, oxygenates our body, super potent antioxidant, nutrient rich, increases cellular energy production. So many benefits it's got. So that's why we always ask our children to eat more of the green vegetable. Apart from your vitamins and this thing, we have the minerals prescribed in the orthomolecular medicine like zinc. Majority of enzymes in the brain are zinc dependent. And it needs zinc to help serotonin convert to melatonin. Copper, the another metal, it needs copper to make dopamine, to make noradrenaline. Low copper can lead to depression thereby. Similarly, we have the magnesium. Humans are most likely to be deficient in magnesium. Magnesium deficiency triggers the mental health problem like depression, insomnia, anxiety, and so many other disorders. So processed food normally have got low magnesium component. So that's why we asked, like nowadays in a diet, is not to process the food. Then calcium, necessary for the smooth functioning of nervous system. Sufficient serotonin activity prevents the irritability and depression. Likewise, we have the iron. We all know it nowadays. I mean, during pregnancy and other, we prescribe commonly. Dairy foods inhibit the iron absorption. That's why we ask nowadays to reduce the dairy foods. Vitamin C supplements enhances the absorption for iron. Anemia leads fatigue. We know all those about these things. Then chromium. It reduces the body fat. High amount of chromium can reverse the atypical depression. Patients who recover on orthomolecular see their skin issue go away in the acne. Acne is a major thing. You see the all the depression problem or the psychiatric patient, if they will have the acne when they undergoes the orthomolecular medicine treatment, their acne issues are going away. So amino acids, we know it, like tryptophan responsible for serotonin, phenylalanine for dopamine. So these are necessary for synthesis of all major neurotransmitters, we agree. So neurotransmitters, these are essential for good mood, like serotonin, dopamine, adenine, noradrenaline, all these act as a messenger. We all have studied in our pharmacology all the time. So example is dopamine. Sign of deficiency is anxiety, low self-esteem, lack of libido, fatigue, all those. Crucial role is in elevating the mood. So what causes the dopamine deficiency is your alcohol or some other drug, caffeine, sugar, nicotine, all these depletes. So the key principles that are involved in OM practice. OM is rest, same as a conventional. Only few important tips are like these are the first priority in the medical diagnosis. Definitely, whenever we go for some medical diagnosis, first of all, they check our nutritional level. So you need to have a sound knowledge about the safety and efficacy of the nutritions, like hormone, enzymes, and all. And it's a primary requirement. That's the first principle. Secondly, is it as it offers, because till now so many reports are there for with the vitamin, the death is really been shown. So it offers a low risk of toxicity in comparison to the conventional drugs. Reliability in OM therapeutic trial and dose titration is the most reliable practical aspect. So there is no standard dose for this. So we go with a dose titration basically. So depending on patient to patient, we titrate our dose and see the response. Biochemical individuality, we have gone through it earlier. It's searching for an optimal nutrient dose is practical concept. Dietary allowance. RDA recommends the diet allowance for the normal healthy person, not for a sick person. So here in for the OM, we titrate the dose. Environmental pollution, as environmental air, water, food pollution is common. So diagnosis of toxic pollutant is also required in this. That is normally in the conventional practice, we don't do it. Optimal health as biochemical need changes. So orthomolecular prescription are also need to change based on therapeutic trial, repeated testing and follow-up. So according to this, the nutrient disorders are treatable and deficiencies are curable. So we should not ignore them. Medical defeatism should not prevent a therapeutic trial. Means if at all any conventional system says that it cannot be cured, means we should not defeat the purpose, and still we can try with this orthomolecular medicine. Therapeutic trial over the treatment with known safety and efficacy. So we have to do the trial of the compound with known efficacy and safety. Reliability of patient report. Yes, it is same as the conventional system. The patient reports are generally reliable. So patient must be listened to his body and physician must listen to the patient. So patient information is given a priority. Patient is motivated, inspired to realize that health is not just the absence of disease. So you don't have disease means you are not healthy. It doesn't mean. So it is an attainment of optimal functioning. Hope. So it gives a hope also. This is another principle. It's a therapeutic principle and is always a source of hope for the OM. So some important aspects of OM practice. Some important aspects are it uses the natural substance like vitamin, mineral, amino acids and all in higher quantity compared to your RDA. In some ill cases, the nutrition requirement is much higher than the normal cases. And in nutrient exerts some clinically useful pharmacological effect in high concentration like ascorbic acid acts as virucidal and antibacterial. Nutrients pharmacological dose can alter the human biochemistry. This is a concept. Some nutrients when administered act as precursor for certain neurotransmitter and prostaglandins. like tryptophan and choline, when administered, increases the acetylcholine serotonin concentration. So nutrient supplementations are indicated in several biochemical and physiological abnormalities. Diseases, processes, or drugs for disease treatment also increases the nutrient requirement. Now coming to the practice. Many physicians in US use OM or mega nutrient therapy in several medications. So these are based on theoretical concepts, the anecdotal or uncontrolled studies, double-blind placebo trials. Scientific ground of OM are increasing, but still amount of research done is small. OM physician often uses combination of nutrients like taurine, magnesium coenzyme, Q10 are established for their use in CHF treatment. Then patient interaction. It follows the same practice like noting the history, examination, laboratory investigation, all those. Herein, the OM collects the additional information, such as during physical examination, may observe nutrition deficiency sign, like white spots on the fingernail, indicating the zinc. Likewise, they just check out the test, the physical testing, they do it for the nutritional deficiency reasons. Certain laboratory tests may also be used to guide the treatment plan. Measurement of your elemental level, like metallic level, like copper and erythrocyte, is done in high dose zinc therapy. Then treatment plan. The OM also classify the disease as per the conventional one, but treatment plan is usually different. Like rheumatoid arthritis treatment conventionally is by the corticosteroids or NSAIDs or rheumatic drugs. An OM physician uses essential fatty acids, zinc, copper, dietary modifications. Otherwise, in conventional, we go with the conventional drugs. So different treatment plans are utilized in the OM practice. Like in many cases, these are administered along with the conventional treatment. In few cases, these are adjusted with the dose, like insulin in diabetes is reduced by supplementation of chromium. But normally in normal practice, we are not doing it. But when we use the chromium, yes, its dose is reduced. Presently, there are no established standards for treatment and condition, although just like physician, based on some research, clinical data, and their clinical experience, treatments are designed. So evaluation of treatment is similar as per the conventional medicine, like osteoporosis. So the duration outcome depends on the nature and severity of disease, patient age, and other factors. So the treatment plan may change based on the therapy response, side effect, and cost in OM treatment. What are the indications for OM? The commonly indications that are for OM are CHF, that's a congestive heart failure. For this, we prescribe generally coenzyme Q10. That is, patient with ischemia or cardiomyopathy possess CQ10 in low concentration, which reduces severity of cardiac disease. Taurine is another what we use. Oral administration taurine reduces severity of cardiac lesion in genetically cardiomyopathic hamsters and induce CHF in rabbits. Magnesium. In cardiomyopathic patient, magnesium concentration were found to be 65%, that was lower than the healthy person. So magnesium, taurine, and CQ10, these are for CHF, like one example I have given. Similarly, for osteoarthritis, we are prescribing niacinamide. So one of the doctor, when he administered 900 to 4000 mg per day of niacinamide to several hundred patients, many patients showed increase in joint motion and reduction in symptoms. So all these reports shows that OM works. Sorry, this mouse is a problem. Maybe I'll remove it, but after that the pointer will be an issue. Okay, sorry. Glucosamine sulfate. In a trial, 20 osteoarthritis patients, when administered the glucosamine sulfate in a dose of 500 mg 3 times daily for 6 to 8 weeks, it relieved pain, joint tenderness, and swelling. So these are the reports. Gingivitis are this gums inflammation. Folic acid, when administered in a dose of 5 ml of a 0.1% solution for 60 days in 30 individuals with gingival health, showed less gingivitis cases. Similarly, in gingivitis, coenzyme Q10 can also be given when administered in a concentration of 50 mg per day. So it showed a good effects. Then similarly, in fatigue, vitamin B12 in a study when administered as IM injection in a dose of 5 mg twice weekly for 2 weeks, it showed significant improvement. Normally, we use all the vitamin microgram doses, but here we are giving in much higher doses. So still it reduced the general, it created a general well-being, happiness, fatigue, and appetite. Similarly, in kidney stone, magnesium hydroxide. When magnesium hydroxide was administered a dose of 500 mg per day for 4 years for treatment of kidney stone, it caused increment in urinary magnesium and reduced the recurrence of stone. So all these are the reports that says the effectiveness of your orthomolecular medicine. In case of osteoporosis also, magnesium was very beneficial when administered in a dose of 250 to 750 mg per day for 1 year. In 31 postmenopausal women, it increased the bone density by 71%. Same way for vitamin K in patient of vertebral crush fracture, mean serum vitamin K concentration was found to be 56% lower than normal individual. Same way, trace minerals, calcium and trace mineral like zinc, copper, manganese, when administered together in postmenopausal women, showed about 1.5 increase in mean bone mineral density. Whereas when calcium was administered alone, mean bone mineral density was decreased by 1.3%. So that means with the trace mineral, it's showed a good effect. Then psychiatry, schizophrenia. In schizophrenic patient, administration of niacinamide in large dose reduced frequency of admission to the hospital. Administration of ascorbic acid in large dose up to 6 grams per day improved the schizophrenia cases. Same way for depression, there are many examples for dementia, for atherosclerosis, and other indications are there in which OM is commonly prescribed. So what are the conclusion and future prospects? Now, how it can benefit to us? Presently, many physicians incorporates nutrition and OM treatment into medical practice. Okay, so as per their clinical experience, physicians believe OM can improve the economy, safety, and effectiveness. With OM treatment, medicine practice would radically change with massive application for public health. Now, what about pharmacy? How we can take a benefit from this? Actually, if you see, this orthomolecular medicine is entirely a new land to play right now. Because in a pharmacy, it's a rare research we people are doing. But I believe if we conduct the research from the point of view from orthomolecular medicine aspect, I think we can achieve the great heights. Like pharmaceutical studies can be designed, especially in the field of pharmaceutics, pharmacology, and clinical research. Like whatever we are doing so far for the pharmaceutical drugs and all, if we plan for the existing natural molecules to the body, like vitamin and all, in the mega vitamin dose, we can easily, I'll tell you, we can easily have the grants. We already applied one grant in Malaysia also. Like it's almost done only. I think we'll be receiving soon. Just to share with you, I think with DIPSAR also, we are collaborating with one project, and we are planning. Dr. Sakshi Bajaj is there, so we are planning a project together. So this is, I'll tell you, so far in the pharmacy, we never play with it. Tomorrow, if we apply in the Ayush, it's a new ministry in India, and NIH, National Institute of Health. So if we apply a grant over there, we can easily fetch it. Just only the requirement will be, we need to have an orthomolecularist for this. So with this, these are some grants list. Like these all are the international grants. And there are many more. Actually, it's more than 70 grants are there. So these are some references. So actually, I have written a book also on traditional, complementary, alternative medicine. If you need to have some more information, maybe you can refer it. So with this, this is our beautiful campus of AIIMS University. So right now I am speaking from this region. So that's all from my side. Thank you. Thank you so much. So now it's over to the board. Thank you.
Thank you, Dr. Neeraj, for your nice and exhaustive lecture. And you have covered so many aspects of complementary and alternative medicine. I want to add one thing over here, because today we discussed about complementary and alternative medicine. I would like to add, this is not the complementary and alternative system of medicine. This is basically the main system of medicine, and the rest of the system of medicine, like the modern system of medicine, they are the complementary one.
Sir, sorry, your voice is coming double. Your double voice is coming. Actually, echo is coming. Sorry.
Yes, sir.
Now it is okay.
Now okay. Now okay, sir. Now okay. Yes, sir.
So I like to add one thing.
Yes, sir.
The complementary and alternative system of medicine like Ayurveda, Unani, and so many others, they are not the complementary, because if you see the history, the Ayurveda, it has been started in the year 6000 BC, and the modern system of medicine, it is started in the year 18th or 19th century. So why not to consider the complementary and alternative system of medicine is just like the main system of medicine, because these are the main system, and the modern system of medicine is the complementary system because it came too much later. It came later rather than the Ayurvedic system of medicine. So as
Sir, I
per
can
my
understand your
opinion,
feeling. Being a cognoscist, it is always that affection is there. But actually, the fact is, today you see the modern I mean, the today's medical fraternity. They all they consider it as a secondary. You accept it or not. Earlier, it used to be the first mainline system, but now the today's in current scenario, they take it like that. But slowly, it is upcoming again because a lot of research evidences are there, clinical trials are going on. So definitely it is coming up again. It is gaining an importance. That's why in India also, they have already created a Ministry of Ayush. So
and
it is
see
gaining
the
importance again, no doubt. That's why the yoga day, it's an international day now. So all these things, people
and
are working on it. That's why. So my main point was, that's why I was highlighting, actually the orthomolecular medicine is also a part of it. It's an open land for all of us to play. In pharmacy, you will agree with me. Very less people they do research on this field, in orthomolecular medicine.
yeah, yeah.
Because moment I was when I came to Malaysia, I see here the Malaysian also they prefer this tradition complementary alternative medicine. So that's why then it create interest in me, and I started working on this orthomolecular medicine. So that's why I came up with that idea. Also, I wrote a book also on that. So I am really fond of, although I'm a synthetic chemist, but still I'm inclined to the this traditional complementary alternative medicine. As per the word, as per the India, it is the first one, no
And
doubt.
there is no single system of medicine who can
True,
provide you complete
true.
solution. That's why the holistic approach is required. And what
Yes,
is the problem with complementary and alternative system of medicine is basically the lack of standardization approaches. So we have to come forward and we have to set
standardization is required.
various standardization protocols for herbal drugs. And in your lecture, basically, you have very exhaustively you have discussed about the role of various nutrients as well as vitamins as well as amino acids, and basically plant are basically the material which are the very good sources of these items basically. And recently the world is looking for, in case of pandemic, the world is looking for the Ayurvedic as well as the complementary and alternative system of medicine, where the modern system of medicine is
I'll tell you,
failed
sir,
to
we have
provide the
submitted a
complete
grant for
relief.
this COVID. From
Yeah.
this only on a COVID also, for that we have submitted a grant, and hopefully we'll get it soon.
Yeah, yeah. And in our university, our honorable vice chancellor, basically, he is working on some plant-based medicine
Okay.
for the treatment of COVID virus, because most of the complementary and alternative system of medicine, they are prophylactic. But we have to consider they are prophylactic as well as therapeutic both. So his product is, I think, very soon he is launching the product against COVID, and that is basically the combination of some herbs along with some nutrients like zinc as well as some others. So basically, this is now the trend is like this. The holistic approach is required to provide the complete relief of disease or ailments. So once
Actually,
again,
are this Ayurveda and all the system, they go with the holistic approach only.
yeah. So once again, I thank you so much because you have spared your valuable time among us, and you have provided us a very good talk on orthomolecular medicine. Over to you, Dr. Bodla and Professor Manju Vyas, and the participant, if they like to ask some questions, the session is open for everyone.
First of all, let the session open for the delegates. Dear delegates, you can raise your queries. Dr. Fuloria is there ready for you.
Yeah, hello, sir. This is Dr. C.R. Patil.
Yes, sir. Hi, sir.
Here. Yeah, hello, sir. Sir, just now you said that you are planning or you are planning alternative medicines.
Sir, come again, sir. A little voice is disturbed.
So, can you elaborate on what is your approach? Hello.
Dr. Patil, you are requested to repeat the question.
Okay. Hello, sir.
Yes,
Just
sir.
now you mentioned that you applied for a project on treatment of COVID using alternative medicines. So can you elaborate on what is your
Sorry,
concept?
sir.
How we can treat a
Actually,
viral disease using this?
on
Yeah, it must be under consideration yet, but still.
sorry, sir. Actually, in that we cannot brief you right now because
Yeah, you cannot disclose. Okay,
yeah,
yeah.
that's a property of the Malaysian government. So
Okay,
we
no
cannot
problem.
disclose until unless it is published.
Yeah. Okay, no
But
problem.
yes, what I told is with
Thank you, sir.
the
Thank you.
this natural molecules, we can definitely go for it.
Mm-hmm.
Now you see people are running around a
Thank you,
synthetic
sir. Thank
world,
you.
but actually everybody, let it be ecology, chemistry, ultimately all are working on natural sources only. For the namesake, everybody is saying the
Right.
synthetic
Yeah.
word, but ultimately all are working on this
Yeah.
natural sources.
Hello.
Right. Thank you, sir.
Right.
Hello. Dr. Ajit this side. Dr. Neeraj sir, this is nice to talk to see, but I want to know something about the vitamin C role in the COVID-19. That is taken by the orally every day by the people, and it is also mentioned in the IUs to take the vitamin C. So, what may be the possibility of that mechanism maybe for the COVID-19 condition?
So this actually vitamin C is, see, for the COVID, what people are doing right now, I'll tell you, they are taking the molecules and they are modifying it. They are going in a combination. They are taking another drug with it. They are not giving a single combination with the natural. Either they are taking a molecule, they are doing the modification, like trying with a polymer, or they are going the same natural with some other natural drug, they are using it. With single vitamin C, they are not going for it. So it's
You
a
also mentioned that in
combination.
some depression or some CNS related problem, vitamin C is also beneficial. So might be some antioxidant property is only thing or something else.
No, vitamin C, antioxidant also, if we say that is, if we, now you are going, I think direct to the molecular level you are going. Okay. In this, what we say is, there are some ROS and all that mechanism you are talking about. So that is the same how we use for others. Here also it is, we are using the same way. But what I'm saying is for the COVID, the plain, if we feel with the vitamin C, no, it cannot cure. But yes, side by blocking the oxidation and all, that way we can do it. Yes. So
So,
it is prescribed with other drugs as a synergy.
so one thing also a point of consideration that doses. The vitamin dosage is very, very important because it is also taken by the just like over the counter drugs. So dose may be interfere. So what is your perception about the dosage of that vitamin?
So doses actually, that's what I was discussing. It depends on bio individuality. For you, the dose can be different. For me, the dose can be different. For you, the threshold level can be different. For me, the threshold level can be different. So in the conventional system, when we give whatever the vitamins today we are prescribing, that is in micrograms.
Good morning, sir.
So what we say is microgram is that concentration is not sufficient enough for a disease. For a healthy state, yes, that can be. In a disease, it is requirement is more. That's what we are discussing about. So that's what we are saying. We can go until the milligram to the gram level. Also, people are going over it. That's a trial. That's a dose titration. We are doing it, depending on case to case. So it's not a one stick for all.
Okay, sorry. Now it was off.
Thank you.
Any other queries?
Thank you, Dr. Neeraj.
Sir,
for
namaskar.
wonderful session. And namaskar. It is always pleasure to listen to you again. DIPSAR, DIPSARU. It is always pleasure to listen. Thank you.
Sorry, sir, your double voice is coming. Your echo is there.
Now it is okay.
Any other delegate wants to interact with our speaker? You're most welcome. Any other questions? Okay.
There is no
So I
question.
request Professor Ajay Sharma sir to kindly felicitate sir with the certificate.
Yeah, please show the certificate.
Sorry, madam, we cannot hear you.
Madam, please certificate लगाइए ऊपर. Please show the certificate.
Hello.
Yeah, ma'am, please.
Neeraj, you are presently closed down for your university.
Sorry, sir.
Is your university working or it's closed?
It's working, sir. From 15 July, it is working, sir.
Even for the students also.
Yes, sir, it is working.
It's working, sir. From 15 July, it is working, sir. Dr. Neeraj, this is from DIPSAR DIPSARU family. You have spared your valuable time with us, and this is basically one type of digital certificate for you. So kindly accept it.
Thank you, sir.
Yeah.
Thank you, Dr. Fuleria.
Thank you, madam. Thank
Thank
you
you,
so
Dr.
much.
Neeraj. Yeah.
Thank you, sir. Thank you, madam. Thank you, sir.
Okay, nice presentation.
Thank you so much, sir. Thank you, everyone, for attending the first lecture of the today's session.
Okay, now over to Bhumika.
Thank you so much, sir. Now, yeah. Before starting with our next session, I'll be announcing the names, and you, the delegates, are requested to kindly introduce us. I'll be giving name. Kindly unmute yourself, start a video, and introduce yourselves. So we'll start with Geeta Muniappa, ma'am. Geeta Muniappa, ma'am. Ma'am, please unmute yourself and start a video. Ma'am, you're not audible.
Bhumika, call another name if she is not audible. Bhumika, call another name if
Okay.
she is not audible.
Jyoti. Dr. Mehul Patel.
Rupali Torath is
You can
there.
even voluntarily just come up with the introduction. You can unmute yourselves and start a video. Anybody?
Rupali Torath is there.
Sir, good morning. Good morning, ma'am.
Good morning. Good morning.
Yeah, myself, Rupali Thora.
Good morning. Good morning, ma'am.
Um,
Good morning.
yeah, myself, Rupali Thora. I'm working as a head of the institute in the diploma college, sir, ma'am, and in Vishal Junior Seva Mandal Institute of Pharmacy
head of the
in Pharmacy
college, sir,
Alapata,
ma'am,
specifically located in
Vishal
Alapata.
Seva Mandal Institute of Pharmacy,
I completed my PhD and M.Pharm
specifically located in Alapata.
in Bharatiya Vidyapeeth College of Pharmacy, Belapur. From last 13-14 years, I am working over here in Pharmacy Institute, Alapata. This is my second QIP program I'm attending on. It's very knowledgeable and also gaining the knowledge in all the newcomers who are entering in the pharmacy faculty.
It's very knowledgeable and also gaining the knowledge.
So on the behalf of Vishal Junior Seva Mandal, we are really thankful for organizing such a wonderful event, ma'am.
So on the behalf of Vishal Junior Seva Mandal, we are really thankful for organizing such a wonderful event, ma'am.
So thank you very much, ma'am.
Thank you, ma'am.
So thank you very much, ma'am.
Any other delegate wants to interact, wants to give an introduction voluntarily? You can start a video. We have Sujit Dash with us.
Very good morning, ma'am. Myself, Dr. Sujit Das from Institute of Pharmacy and Technology, Salepur, Odisha. Myself, Dr. Sujit Das from Institute of Pharmacy and Technology, Salepur, Odisha. I'm working as an assistant professor here from last 13 years. And I'm working as an assistant professor here last 13 years. And I'm very much fortunate enough to be a part of this type of QIP organized by very much fortunate enough to be a part of this type of QIP organized by and I got very good knowledge from the prominent speakers and I got very good knowledge from the prominent speakers and so I am hoping to get be a participated in the coming QIP also get be a participated in the coming QIP also. Thank you very much, ma'am, for accepting my participation application, and I hope that I will be doing the QIP accepting my participation. Thank you, ma'am.
Bhumika? Good morning, Dr. Sanjay Jachak.
गुड मॉर्निंग मैडम, गुड मॉर्निंग, कैसे हैं?
Yes.
बस ठीक।
Yes.
नहीं सब ठीक।
Good morning, sir.
Good morning.
So our next speaker has joined.
We have our next speaker with us, Professor Sanjay. I request Professor Ajay Sharma, sir, kindly introduce him to the delegates.
Good morning, Professor Jachak.
Professor Ajay.
Yeah.
Good morning, Ajay ji. Good morning,
Professor Jachak.
Anjay.
Yeah. So, Bhumika, kindly show the CV of sir.
लेकिन अभी शेयर नहीं हुआ है।
Yes, sir.
Dr. Ajay?
Yeah, ma'am. Yeah.
You have shared.
Yeah.
His CV.
Professor Jachak, am I audible?
Yes, very much. Yeah.
Okay. So, good morning, Professor Sanjay Jachak and the other participant for the second lecture of 35th QIP program organized by DIPSAR and DIPSAR family. Professor Sanjay Jachak is working as a professor and head of the Department of Natural Product, NIPER Mohali. He is basically the member joint entrance examination, that is JEE of NIPER 2015 and 17. He is coordinating NIPER SAS Nagar. He is the member statutory committee of the institute such as Senate from the year 2004 to 2007 and 2012 to 2014, then again 2016 to 18. He is the member of Board of Studies and Research of NIPER. He is the course coordinator as well as the technical courses sponsored by AICTE, Special Commonwealth Africa Assistance Program, that is SCAAP, Ministry of External Affairs, Government of India, uh, 2013, continuing 12 ITEC courses on various themes related to pharmaceutical sciences were organized during 2013 to 2019 and imparting training to 400 participants from 52 ITEC countries. He has completed his doctorate degree in the year 1997 from Austria and M.Pharma in 1994 from Pune. He has more than 25 years of teaching and research experience. He has guided 14 PhD and 87 master's students for their research work. He has published 105 research papers in peer-reviewed journals of national and international review. His H index is 31 as per Google Scholar citation. The total citations are more than 3,500. He got 70 million Indian rupees as an extramural grant from CSIR, Department of Ayush and DBT, Government of India. He is the recipient of various awards and honors: Farm Innova Ahmedabad Best PhD Thesis Award as a Research Guide in the year 2017, Most Cited Research Paper Award, Bioorganic Medicinal Chemistry Letter 2005 to 2008, and a research fellowship from Austrian Academic Exchange Services, Vienna, Austria, from 1995 to 1998. Sir, I welcome you all in this QIP program, and we are fortunate to have you as a speaker in this program. Over to you, sir.
Okay, so am I allowed to share my screen? So
yes, sir.
I can click the option. Let me try first. Yeah. Is it visible?
Yeah, it is coming, sir.
Yeah. It is a message is that your screening sharing is paused. Maybe I think it has to be.
Madam, kindly enable the screen. I think it is disabled from your side.
So from our side, it is okay.
Yeah, let me try again. New share, maybe.
Yes, sir.
Is it now visible?
Yes.
Yes, yes.
So I'm making
Yes,
it
sir.
to the presentation mode. Okay, so first of all, let me congratulate DIPSAR and the organizers for arranging very important and timely topic under this electronic version of faculty development program. And I'm very also happy to see that this is a 35th maybe FDP that they are doing in the series of FDPs that DIPSAR has been organizing. And I'm also thankful to Dr. or Professor Manju Vyas and my junior and friend colleague, Dr. Sharad Vakode. So we are actually, that reminds me our old college days. He was 1 year junior to me. I hope he's online. Sharad, he is listening. So
Yes,
Please.
yes, sir.
Yeah. So with this,
Pleasant.
it's pleasure. Yeah, pleasure to talking to you again. So let's see now the today's topic as per the theme of the FDP. I have selected to talk about this phytopharmaceutical product development. As the title says, a paradigm shift in the field of herbal drugs and natural products. As all we know, this is the upcoming area, and I think it's the teachers who are the participants audience in this program, I guess, from various pharmacy colleges, institutes across the country.
Yes, yes, sir.
Yeah. So I just want to tell them that here is the exciting opportunity. All are listening, like especially whenever I get such forum, many such fora in the, let us say, national, international level, we see that I don't want to undermine any field in pharmaceutical sciences, but the pharmacognosy field is downgraded like anything. Over the years, what I am seeing, M.Pharm pharmacognosy is closed at many institutions. This is really very, you can say, frustrating to many people and not good sign, because this is one of the core branches in pharmaceutical sciences. But the way it is being done, I really don't know, because we have seen a lot of future scope in the Western world. When I was there, I keep going. I am member of this Society for Medicinal Plant Research and Natural Products continuously, that is GA, Germany. So they do a lot of very state-of-the-art applied research in this area, and it is one of the very important and valued research area. But I see completely opposite picture when it comes to the national level in India, and all generics we are talking about Sutics and drug delivery. That's all. But there are a lot of scope. We can do those things here. That's why I want to tell all the teachers, like, the opportunities here. So drug delivery, you can definitely do a lot of research in these areas. Either you say a nutraceutical, today's that is not the topic, but it is on similar lines. You have a product development which has direct commercial application in the form of a nutraceutical product. And today we are talking about a little improved version of a nutraceutical product, I would say a phytopharmaceutical product. So as the name indicates, a phytopharmaceutical, so obviously it is coming from a plant. And of course, we are talking about a medicinal plant. And this is the first of its kind. It's the first new drug that has been approved by DCGI in the year 2015 under the category of new drug, phytopharmaceutical, for the first time in the world, which is very, I think, encouraging, you can say, step that is taken by government of India and let's say DCG and CDSCO headquarters at New Delhi. They have introduced this very exciting category. At the same time, many colleagues will have a question in mind. So what is the status, whether anything of such drug in the market? So the answer, unfortunately, as on date, no. But so, several of them are under, you can say, clinical development and approval stages, as you will see. But in the market, we may expect in the next 2 to 3 years, first 1 or 2 phytopharmaceutical product definitely will be in the market. So this is the new area where a lot of opportunities are there, where it can give a lot of impetus and stimulus in the research of herbal drugs and natural products. So with this background, let me go to the disclaimer slide. So these views expressed in this webinar are my personal and that do not necessarily represent my institute or employer. So first, as per the definition given by DCGI as published in the Gazette in 2015. So as you can read through, I will read through. Phytopharmaceutical drug is defined as a purified and standardized fraction. We define minimum 4 bioactive or phytochemical compounds, qualitatively and quantitatively assessed, of an extract of a medicinal plant or its part for internal or external use of human beings or animals, for diagnosis, treatment, mitigation, or prevention of any disease or disorder, but does not include the administration by parenteral route. So this is actually very important, that phytopharmaceutical is not recommended to be delivered by parenteral route. So this is important definition. I will elaborate further. This is very important. The things which are made in bold at the beginning, in the bold font, that is purified, standardized fraction, and minimum 4 bioactive or phytochemical compounds. Because when we are talking about a product like conventional pharmaceutical product, let me compare that with this phytopharmaceutical product. So we have a active pharmaceutical ingredient, API, in any formulation that we make. So here the active ingredient is APPI, active phytopharmaceutical ingredient. That is what we call it here in APPI, in this case of phytopharmaceutical. And this is not an extract, as it is mentioned. You see here, it is an enriched fraction, basically. That people have to understand. It is not an extract merely. Extract, if you will agree with me, as our experience with several years tells us, extract is a very complex mixture, okay, of 100 to up to 200, sometimes 250 compounds with varying percentages of their contents. And also you can say, in a way, it is a very complex mixture. So it will be very difficult to have a quality control or the product development from such a complex active ingredient like an extract. So in this case, they have recommended that we have to prepare an enriched fraction from an extract, which will be basically a purified, you can say, form of an extract, and that will be quantified qualitatively as well as quantitatively for 4, first I will say, phytochemical compounds. Why? Because whenever we are talking about a product, of course, you need to have its proof of concept of efficacy, what is its bioactivity. So if you can correlate the observed bioactivity for which the product is to be targeted, so that bioactivity, if you can correlate to these 4 phytoconstituents, which will be qualitatively and quantitatively assessed, it will be a plus plus, and that is what actually is ideally desirable. But many times that don't happen, and we have to also ensure that there is a batch to batch consistency. When this is a major challenge when we talk about a medicinal plant, like I will give the example, our case study later on, but you take, for example, I'm giving very simple example, all of you will agree, like Terminalia arjuna. This is a plant we are working for some time now. All we know, it is abundantly available throughout India. So bark of the plant is very high valued for cardiotonic properties, cardiovascular diseases in Ayurveda. So if you see that the content of the active ingredients, which are the pentacyclic triterpenoids called arginolic acid, arjunic acid, arjungenin, arjunatin, and related compounds. So if you see, their content will vary in the bark that is collected from, let us say, Chandigarh, and bark that is collected maybe at the DIPSAR campus, or you go little down, you go to let us say Gujarat or Maharashtra or Karnataka, you will have a different composition with respect to content. Compounds will be same, but content will vary. So this is what batch to batch variation we have to make ensure when we talk about that their content remains same. This the manufacturer has to ensure, otherwise all its efficacy, safety data will vary if the content and composition of this bioactive fraction, if that varies. So this is the, in a way, is a big challenge when we talk about even this pharmaceutical new drug category. It is not that straightforward as we are discussing. When it comes to working on the bench, you face a lot of difficulties. When you work with the extracts, as I already mentioned, they are the complex mixture up to 300 compounds. Secondary metabolites of different kinds, or also sometimes primary metabolites we come across. It's in the mixture form, that we call it as an extract, that is prepared by several methods from a medicinal plant. So this is what, just a nutshell, little bit about the active ingredient I wanted to talk, and with the example, it will be more clear when I will discuss later on as a case study. Then any drug which is launched under the categorization of Ayush must provide in vitro bioequivalence with the reference standards as set in pharmacopoeial monographs. But in case of phytopharmaceuticals, it is mandatory to develop non-clinical as well as clinical data of the phytopharmaceutical drug, because we know now it is a new category of drug, and as of now, CDSCO has not decided any format, monograph format for this drug. As I told you, not a single yet in the approved in the market. So, or for the marketing authorization has not been given for any single phytopharmaceutical product as on date. So for a drug to be classified as a phytopharmaceutical, there has to be a lot of emphasis to be given on available information on the plant, formulation and route of administration, dosages, therapeutic classes for which it is indicated, and the claims to be made for this product, and supportive information from the published literature on safety, efficacy, and human or clinical pharmacological information. You need to compile everything as you are compiling the data that is made from different, you can say, safety and efficacy studies, preclinical as well as clinical. So data generated generally on the identification, authentication, and source of plant used for extraction and fractionation. Process for extraction and subsequent fractionation and purification. Formulation details of phytopharmaceutical drug, manufacturing process of formulation, and stability data. So you can see you have to generate a lot of data, and it starts with very important thing, like you will be wondering which plant we should select, what are the criteria for selection of a plant for phytopharmaceutical product. So the plant should be such that it is available easily, it do not have any conservation issues if you go on collecting on large scale, because if you want to commercialize it, it should be available plenty on industrial scale. So this is another major challenge. Hello.
Sir, please go ahead.
Yeah. So what I was talking about, the selection of the plant. So it should be available plenty, well established, and it do not have any conservation issues. So those are the things. So one has to also try to see whether you can try to obtain this identified plant material from a cultivated source rather than relying on the wild source. So this is another major challenge that we are facing in this field, as the government has taken the bold step, but still these are certain issues at the ground level, ground root level has to be addressed. How to procure and make available the selected medicinal plant for this product development as we are talking about. And then of course the identification, authentication has to be there. So in the identification, authentication, if there are some problem, some controversial species if you have, then the conventional methods of authentication, like we are having as per WHO document, we have to do around 12 to 13 different parameters in ensuring the quality control of this raw material. But if you have such you can say species where there is a confusion, there is a controversial, they are in nature in terms of their identity, then we have to do also DNA fingerprinting for the identification of the exact plant species, authentication and identification before you select for your work and further product development. So these are the important aspects when you select the medicinal plant in the, let us say, phytopharmaceutical product development. Now the regulation, 2015 regulatory requirements for phytopharmaceuticals are under the purview of CDSCO. This gazette notification, you see Schedule Y, Appendix 1B actually defines regulatory provisions for phytopharmaceutical. So you need to see all the details if somebody is interested to see what are the checklist and requirements that you need to have or you need to take into consideration before you start this work on phytopharmaceutical product development. Schedule Y, Appendix 1B, one has to see that. And the regulatory submission requirements for scientific data on quality, safety, and efficacy to evaluate and permit marketing for an herbal drug on similar lines to synthetic or chemical moieties or API, as we are talking about, based formulations and products. So new phytopharmaceutical regulation permits the development of new drug development using advanced techniques of solvent extraction, fractionation, potentiating steps, modern formulation development, etc. Now I would like to say, like, if you want to commercialize this phytopharmaceutical product. Academic partner alone or an academic institution alone cannot do this task. So you need to have industry partner. So if you want to have the industry partner, the industry will not come to you just like that, unless and until you have some novelty with it. So how the novelty will come? Because the botanical is already known. So you cannot patent that. But what you have to see, like I mentioned about the fraction, which is prepared from the extract, the complex extracts. Let's say it is prepared by using methanol as a solvent. As we are talking about solvent extraction, you use maceration or any other technique of extraction like supercritical fluid extraction, which is the now much needed technique in the recent times. When we talk about the residual solvent impurities, this is the best technique what we can use, supercritical fluid extraction over the conventional solvent extraction method. So there one need to see actually the extraction and then the fraction I was talking about. If you develop the fraction, enriched fraction, which is showing by activity, and that is quantitatively and qualitatively estimated by LCMS, HPLC coupled to mass and HPLC, then in that case, you can have the process patent on the preparation of enriched fraction. So unless and until you have that, no company will come and talk to you if you have this phytopharmaceutical product to be developed, or that is the objective. So this is very important when I'm talking about the, let us say, advanced techniques in preparing actually the enriched fraction, that you can definitely patent, and then obviously company will have the confidence that you have something. And of course, then the safety efficacy data is also very important that you need to have along with all this. So after the new drug application approval from CDSCO, the marketing status of the new phytopharmaceutical drug would be like that of a new chemical entity based drug or as a conventional based drug, as we can see. So the new regulation for phytopharmaceutical is in line with the regulations in the USA, China, and other countries involving scientific evaluation and data generation on botanicals or on medicinal plant materials. So why I have mentioned paradigm shift in the title. Now you will just see from this slide, I just want to again tell you things like the paradigm has evolved identifying one cause of a disease and one chemical entity to correct that cause. So the traditional system in many countries, cultures, which has used extracts from natural sources, has by and large been ignored since several, you can say, years or decades, as we see. Thus, the traditional systems of medicine, medicines which used various natural sources and their extract has not found use in modern medicine. But as when we talk about natural products, these are the secondary metabolites, either in medicinal plants, microorganisms, fungi, marine organisms, animals, and many other sources. So whatever secondary metabolite we get from that is called as natural product. And as all we know, the 60% of the drug that we use today, I mean to say small molecule drugs, 60% nearly have come from natural products, NCs. So you can see here, here you have to make clear-cut demarcation. These natural products have been the source of drug molecules. Okay, but here we are talking about, let us say, the traditional medicines where the basis was there, and then those medicinal plants or different other natural materials were taken, extracts were prepared and put into drug discovery programs to lead to NCs. But here, as we are talking about the, let us say, extracts to be used as a medicine as such, and now we are talking about a purified extract. So it is the differentiation that you need to understand. But as a whole, what I want to convey, natural products and traditional medicine definitely has been, is, and will be a future, definitely will be an attractive source of always the drugs and drug products in times to come also. So that's what we are discussing. Due to increasing debates and concerns over the years, the US FDA in 2005 finally recognized the class of medicine in terms as botanicals. Now, if you ask today also phytopharmaceutical drug, as we say in India, they will be calling it as a botanical drug in the USA, which are plant-derived natural extracts and complex mixture of compounds So botanical drugs are not necessarily purified chemical entities to treat a disease. The same class of drug was also adopted in India as phytopharmaceutical, as we discussed in the previous slide, in 2015, and few phytopharmaceutical products have under different stages of development currently in India. So this is what, as we are talking about, we are going through pandemic. That's why we are talking online. Otherwise, we would be meeting in DIPSAR if the normal situation. Now you see with this clinical trial of the extracts from the plant Cocculus hirsutus, in Hindi called as Patal Garudi. Many of you might have read it, made the news in May, June this year, that phytopharmaceutical was approved by DCGI for the mild, for treating the mild cases of COVID-19. So this particular, you can say, venture it is spearheaded by Sun Pharma in collaboration with two CSR labs, ICGB in Delhi and IIIM in Jammu. So one of the investigator in IIIM Jammu is our own student from our department. He is doing this work. Earlier, then he told me the details, Sun Pharma, how they got into that, because they are working since 2016 on this plant for the treatment of dengue. So you know, so dengue virus and this SARS-CoV-2 virus. So they have the similar kind of, you can say, expression once they enter into the body. Only the attachment mechanism entry into the body is different. Rest, almost it is similar. So on those lines of their data with dengue virus, this express approval was given by DCGI for the first phytopharmaceutical to treat mild cases of COVID-19 infection. And this is what I have mentioned here. They abbreviated, Sun Pharma abbreviated this as AQCH, the name of the drug. On 5th June 2020, the approval was given. And you see the phase 2 clinical trial was initiated subsequently in July 2020. Across the 12 research sites in India, where this drug is being evaluated on 210 COVID-19 patients for what will be a treatment duration of 10 days. And results of this trial currently are expected to be completed as we are talking by end of this month or maybe by next month. So this human safety study of AQCH has already been completed and the drug has been found safe at the recommended dose for the phase 2 study. And drug has also shown anti-SARS-CoV-2 effects in the in vitro in cell culture studies. So this is what actually we are looking forward, but this unfortunately is only available at 1 or 2 places as of now in India. That is NIV Pune, where it is there. Rest I don't see any lab yet has this cell assay to do this anti-SARS-CoV-2 activity. So all this work, whatever we are talking about, it is done by Sun Pharma in collaboration in their, I think, plant, in their R&D center and the labs in UK. They haven't done here in India these studies for the cell-based assay against this anti-SARS-CoV-2 activity. But that is how the status is and it is going on. So why I'm telling all this now, you see in the pandemic, the first drug approved from India is not the conventional phytopharmaceutical, as all we know, conventional pharmaceutical drug, because we know it's repurposed drugs. They are being used like remdesivir, favipiravir, all you know. So those are being used, recommended for treatment. But this is now the first example. As I was saying, there is not a single approved as on date. This is still under, I think, clinical trials are going on, but express approval is given looking at the pandemic situation. And now you can see there is a lot of, this is a kind of motivation, stimulation, those who are working in this field of natural products, that we have here the category where definitely with good academic research combined with industry partner, we can definitely have inroads to make in a way to find, you can say, a new drug that is coming from natural products and especially the medicinal plants that have been described in our traditional systems of medicines. So with this, you can say, introductory remarks, few plants I will discuss first, and then I will give our case study one example that we are developing currently as a phytopharmaceutical product. So first, all you know, licorice, we are studying since our B.Pharm days, all of us. Actually, many of teachers are also are well aware. Lot of practicals are given on this plant, but still it is a wonder plant. As you see, Glycyrrhiza glabra, more than I think 50 different flavonoids, including chalcones and flavonones, have been isolated from the roots and rhizomes of this Glycyrrhiza glabra licorice. So total of 19 compounds we had isolated from different active extracts. As our one of the major research area in the department is, apart from the in the lifestyle diseases, inflammation, cancer, and obesity. So this was studied for the for obesity. So you see that in vitro studies on the isolated compounds showed that chalcones are mainly responsible for the observed anti-obesity activity, like isolicuritigenin or even licochalcone. So these are the two chalcone compounds which are showing activity in the in vitro as well as in vivo models of obesity. So this was one compound. Then, as an academic interest, part of PhD thesis dissertation work, we have prepared several semi-synthetic, synthetic analogs of chalcones. As we know, they are the starting material, even to prepare several different classes of flavonoids synthetically. So on that way, some studies were done. We try to optimize and let us say the activity of the isolated chalcone isolicuritigenin. But the point here is that we can take such plant which is plenty available for the, you can say, phytopharmaceutical product development, which is easily available. The compounds you can isolate, and 4 compounds you can easily pinpoint qualitatively, quantitatively you can prepare. Only thing you need to prepare that fraction, how that will vary from plant to plant, and let us say the type of extract. So this all we know. The compound now, all we know now in this pandemic again, this Ayush recommends 3 medicinal plants and their extracts, Tinospora cordifolia, Withania somnifera, and another one just now I talked, licorice, Glycyrrhiza glabra, for you can say boosting the immunity. So this is one such plant where one can definitely think of making novel phytopharmaceutical product from the Indian ginseng, as we call ashwagandha, Withania somnifera. And this is another very, plant where a lot of variation has been detected. And again, here also, when I was going through literature, so nearly 70 to 80 different withanolides from whole plants have been isolated and characterized. So this is, you can say, another, you can say, powerhouse of a very interesting class of, you can say, steroidal lactones, as we are seeing the structures, withanolides. Very interesting compounds from chemistry point of view as well. So this is what the plant we have, but unfortunately very less studies which are going to the conclusion. The conclusive studies are not there. Here and there many studies, but incomplete studies are there on the all you can say immunomodulation aspect of this particular plant, the extracts prepared from Withania somnifera. All we know, turmeric, haldi. So what to talk about that? Even in the USA, people were talking about haldi latte. Now we know Ayurveda call it as a golden milk. And this is another very important thing which you can take as a preventive medicine for many things, all cardiovascular problems, and even boosting the immunity. Nowadays, as we all need immunity busters, looking at the spreading of several infectious diseases like viral diseases we are facing. So this is another one very important spice that we use in our day-to-day kitchen. But most of the time when we cook, the compounds are degraded during the high temperatures in cooking. So best way is actually you just take it in warm milk, in 1 teaspoonful in 1 cup of milk. That is good enough every day one can have. So 2 to 3 grams. Quantity wise, if you take in 1 cup, should be good enough to give you protection. So this is what is another thing people are practicing. Even in COVID centers, I have seen quarantine centers, they are giving all these immune busters and this golden milk as prescribed by Ayush also, Ayush Ministry. So citral, as all we know, it's common, you can say lemongrass that is being used for several, it's essential oil. for several diseases that can also have its own importance. Then psyllium husk Plantago ovata, as all we know. So it is mainly the mucilage, the mucopolysaccharides, and some phenolic compounds like mentioned here are actually important for exhibiting the or for responsible for the laxative effect of this particular psyllium husk. Then chia seeds, as all we know, the source of omega-3, omega-6 fatty acids are very important in our diet. These actually are also important for boosting the immunity, lowering blood pressure, and improving heart health. All these, so many of the nutraceutical products you will see they have the omega-3 or omega-3 fatty acid sources added in them. And then even this is another company, I think a few of our students are working in, this is in Baroda, that is actually Farmenza Herbals. So they are developing a phytopharmaceutical from saffron. So that is one of my student who is there. They are collaborating with us. He is working on, let us say, different these carotenoid pigments that we see in this crocin and as to like crocin in saffron, but only issue is authenticity. It is not available, as all we know. It is available only in the high altitude regions in Himalayas, in Jammu Kashmir, as well as in Himachal Pradesh. So there only we get the authentic, and it's you can say sourcing at large scale. It is not available. That is the challenge actually. If you go for the product development from this particular plant. Crocus sativus, saffron, as all we know, kesher that we use in also in foods to give very nice coloration. If you see, it is being added kesher, as all you will agree. So this is one such important, you can say, source which can be useful in developing the phytopharmaceutical product for lifestyle diseases due to very interesting biological properties of these carotenoid pigments that are present here. Now I am coming to the work that we are doing. Now you will be wondering, this all we know, every one of you. So in the south it is very popular than in north, what I see. So all we know, like curry or sambar, that is incomplete without curry patta. So this is the plant curry leaves we are working on, and as a phytopharmaceutical product, because the very simple reason it is available plenty. You can cultivate it, as in Nipur campus, we have, I'm very lucky to have around 20-30 acres of land totally given to the medicinal plant garden cultivation and the field laboratory. So we have cultivated our own 2 different varieties of Muraya konigi as a curry leaf, and very interesting results we have with respect to the treating obesity with this, let us say, because I see when we eat this, whether it is in poha in Maharashtra or let us say curries in South India, people take out this and throw it. They don't eat it actually when I see that. So, but that should be eaten, that should be taken. It is having very wonderful, you can say, effect on the lipid profile, this particular extract and compounds when we studied. So this is the plant, why it was selected, because it is throughout the India, it is available. Okay, there is no issues of conservation. So if you want to go for commercial scale, you can easily get this material plenty and do that. Now this is also called as mithanim. If you see, we know Azade recta indica, that is neem, and this is Muraya konigi. It is also, you can say, same family, but this is sweet, means it's not sweet, but compared to, as if you have tested the leaf of neem, so bitter. So compared to this leaf is not at all bitter. If you eat, you can chew these leaves as such also. So that's why this is also called as mithanim in Ayurveda. This particular plant, when we know curry plant, as popularly used spice in India. So that we are developing a product out of it. Several studies have been done in the last 6 to 7 years on this particular different aspects of this plant. And we have also done the seasonal variation for a period of 1 year and different locations. We know exactly now what is the batch to batch variation that would likely to have, that you can contain, control by doing such studies that has been done. And the marker for this plant is Mahanimbin. which is, as you can see, the structure, which is a carbazole alkaloid, an interesting class of compounds, as you can see, which is attached to a chromin ring and has the alkyl chain further. So with different structure, you can say substitution on these carbazole alkaloids. When I looked at the literature, when we started work, I was amazed to see at least 40 alkaloids. And then over the last 4 years, there were many more alkaloids reported. And when I see the literature, this is really, I mean, the wonder of natural products. The curry leaves, actually, when I'm talking about this part, as all you know, it has around 30 alkaloids. And if you see the stem that we don't take, we throw, and the major stem, there are also another 30 to 40 alkaloids. So nearly 80 alkaloids of this skeleton are present in this plant. So wonderful to know and investigate. So we are, one of my PhD student has isolated so far 15 different carbazole alkaloids, and we are isolating many more. But that we don't need for different purposes. For phytopharmaceutical, I need only 4. But as the part of exercise training to the students, so it's very interesting. We wanted to know what is the structural variation in these compounds, whether we can see some, you can say, aspect as taking one of the structures, like clausazoline is one of the simpler alkaloid. We can take as a lead and make several analogs. We can make that synthetically also and put it into a different medicinal chemistry program. So this was the idea to go about the, you can say, phytochemistry of a very well-known plant, as you know, as we are talking about. So that is what in the recent years we find. So this can also come under the category of functional food for obesity, for example. So this is a study. So from 34 plants that we have selected around 8 years back for doing the screening in the pancreatic lipase in vitro inhibition assay, enzyme inhibition assay, 102 extracts from 34 plants were screened for this activity in vitro. And out of that, these were the most active. And there are further, we have graded based on activity these plants. 10 plants were shortlisted, 2 were the best one. These are Glycyrrhiza glabra, I talked earlier, and Murraya konegi. So they were the most potent among these 34 plants. So we have, you can say, focused and sized down our work to only these 2 plants. This is completed. And this we are taking to the commercial scale now with the industry partner identified recently. So Murraya konegi leaves. So besides these, it has been suggested that mahanimbine and isolicrutiginin may give new PL inhibitors, pancreatic lipase inhibitors, as a functional food ingredient in prevention and treatment of obesity. So the findings, our findings also confirm the potential of Indian medicinal plants as a source of anti-obesity leads of pharmaceutical interest. And from this, as I just talked about, leaves of this plant, several carbazole alkaloids were isolated. Out of that, the major alkaloid, it is present around 0.5%. So it content varies from 0.4 to 0.55. As I was talking about, that we have seen seasonal as well as geographical variation. Nowhere in the literature, this study is there. So we are about to publish this study also with respect to phytochemical analysis of these alkaloids of Murraya konegi. And it showed the IC50 value of 17.9 micromole in the pancreatic lipase assay initially. Then we have taken to the cell-based assay and doing its activity that has been still going on. So in our laboratory, we had investigated the methanol extract, then the enriched fraction, as I was talking about, that is needed for phytopharmaceutical product, that is the alkaloid enriched fraction that was prepared. And one of the bioactive compound from this enriched fraction is, of course, the major constituent and marker, chemical or analytical marker, you can say. Now also I can say a biomarker for this enriched fraction of this plant is mahanimbine, apart from other alkaloids for anti-obesity activity. So extract, alkaloid enriched fraction, and this compound found to be non-toxic to cells when studied using MTT cytotoxicity assay as per the standard protocol for 24 hours and the continued study for 10 days in cell-based assays. We found that this is absolutely safe. So this fraction was then studied against adipogenesis process at 10 to 50 microgram per ml concentrations. in murine 3T3L1 pre-adipocyte cells. And after the in vivo studies, we have performed the in vivo studies. Yes.
Sir.
Some disturbance. Okay. Yeah.
You continue, sir.
Yeah. So the in vivo studies, like we have the mouse model of obesity, and people also do, like I have discussed with one of our students in CDRI, who is already a senior scientist there. They are doing in actually hamster. So he says hamster is better than mice, but we have done the studies with mice. But let's see, we may also do it in hamster later on, because there is a lot of animal protocol, lot of requirement of animals. It is not that easy, but we want to do that there also. But results in mice were also very encouraging. Mahanimbin at 2 mg and 4 mg per kg per oral administration, or chronic supplementation prevented HFD-induced weight gain and changes in anthropometric parameters of mice. It alleviated systematic effects of excessive fat-based diets such as lipidemia, adiposity, fatty liver, followed by the consequential systemic secondary inflammation and oxidative stress, and several other ghrelin and other related parameters and markers of obesity. Even the HDL, LDL level, then triglyceride level, all have been studied in detail, and there were very encouraging results with the enriched fraction and compounds. So mahanimbin, as I already mentioned, it is present in 0.5% weight by weight derived leaves basis in this Murraya Koenig leaves. The major carbazole alkaloid present in the curry leaves is responsible for anti-obesity activity exhibited by alkaloid-rich enriched fraction of the leaves. Further, 3 more carbazole alkaloids, that is coenimbin, conigicine, and quinine, were isolated from this fraction, and several others. But we are estimating these 4 as per the requirement. Already we have estimated qualitatively as well as quantitatively as the first requirement in the phytopharmaceutical active ingredient. And the enriched fraction is standardized with respect to all these 4 phytoconstituents, and that is what I said. This work is under publication, and process of preparing enriched fraction is under patent. So process, so that we can, once it is shortly there, then the company will come forward. They are already identified. They are interested to prepare either a tablet or capsule formulation out of the, let us say, enriched fraction for treating obesity. And even if we get the model, like we want to study in the comorbidity in the COVID-19 patient, that talks are going on the extracts of this particular plant, Murraya Koenig. So these are the related alkaloids few. Just I was telling, with some substitution variations on the carbazole alkaloid, you have very closely related structures, and around 30 carbazole alkaloids itself are present in the leaves that we are taken as a material to prepare the phytopharmaceutical product. And what you need to have the very you can say elaborated detailed isolation, phytochemical isolation work, the method development, HPLC method development, which will be useful for the quality control of the active fraction, then later on the formulations that we should have. So before we did HPLC method development, LCMS was done, and then these carbazole alkaloids were identified, and then they were isolated. Okay, so isolated, and then simultaneously the HPLC method was developed. And you can see, I will show all these details. You can later on see, these are the reverse phase HPLC conditions with the buffer in the mobile phase gradient elution at 254 nanometer detection. That what I see, these are the, you can say, major peaks. There are several small peaks which you are not seeing due to this high absorbance intensity peaks in the extract. Otherwise, here, if I show you, here at least here there are 6 to 7 alkaloids that we hardly see, but they are there. And then these are the major ones. So this is a peak of mahanimbin at 22 minutes. Okay, and then several other we have identified in that, quantitatively done. So likewise, you need to first do the LCMS analysis, identify those, isolate, and then you determine, then you know individually, once you isolate, we can spike and tell which is which in this particular complex extract. So this is the methanol extract, which is prepared by maceration method. We have also prepared the supercritical fluid extraction method. I have not shown the chromatogram, but there I see the content of alkaloids has been drastically increased as compared to the conventional extraction method like methanol using as a solvent and supercritical carbon dioxide with 5% methanol as a co-solvent. You got very wonderful extract, that is clean extract from the supercritical fluid extraction method. So, but this is what you can see the chromatogram looks like. Here are also a lot of compounds, as you can see there. There are some flavonoids here, glycosides. They are also there along with the, let us say, in the extract. But when we prepare the enriched fraction, that process is under actually patent that I am not disclosing. But you can see the absorbance and area wise. We see there is an increase in area under curve and even the absorbance 0.6, now here 0.8 if you see. So there is clear-cut enrichment. Okay, at the same concentration, 5 mg per ml, 10 microliter was injected into HPLC. And this is what one need to actually do the batch-to-batch variation and standardize your enriched fraction. That is to be converted into a drug product, and several other pre-formulation. Then this preclinical study, safety study we have just completed, and with the data that is now under CDA is being shared with the company. Once the patent is filed, we are hopeful next year we can start some work on commercial aspect of this. Due to pandemic, this is all delayed, but I hope next year we'll able to do something on this aspect. Okay, so with this, just give me, if I have 5 minutes, I will just tell about my department that I'm working. Yes. Yeah, is it fine?
It's fine, sir.
Yeah, that is all I wanted to tell about the phytopharmaceutical. Just here I'm working since last 22 years at NIPER Mohali. Since the beginning, this is one of, from the inception, one of the major departments, core sciences in the area of pharmaceutical sciences here at NIPER. So we work in different areas on the basic research as well as the translational applied research that just I discussed, as the nutraceutical and phytopharmaceutical product development. Then the new chemical entity research for the, you can say, different areas like infectious diseases, lifestyle diseases, and even we are working on the antimicrobial resistance, AMR, in collaboration with Intech Chandigarh, with the natural product leads for treating the escape pathogens, pathogen infections, and so on. So those kind of things, and this is the mega projects that we are working on, sponsored by DBT with the collaboration in Intech, and then here at IHBT, Palampur. That is another CSR lab, AIMS Delhi, the formulation development. That is actually Seabakton, Layberry. So these are some current projects that are underway, which we are looking forward to have the product which is commercialized from this research. And as of now, we have published more than 395 research papers, and we have, I think, altogether more than 10,000 citations on these papers, and with different impact factors. Apart from that, the monographs, and they were prepared, published in Ayurvedic Pharmacopoeia, ICMR standards for Indian medicinal plants, and also on formulations, Ayurvedic formulations. And this is where I'm sitting right now. Here, this is my room is there on the, sorry, here in the first floor of the C block. So we have first floor, second floor, Department of Natural Products in NIPER Mohali. So most of you, all of you, whenever the chance comes in future, are welcome to visit NIPER Mohali, to our department. And that is what I have the luxury, very lucky to have the field laboratory where we do the processing of plant materials on small scale, pilot scale, as well as large scale. And we have here around the 20 acres of cultivation land, and around in half an acre, we have developed the state-of-the-art medicinal plant garden at our institute. So this is where I think we are very lucky, I would say, to have this kind of infrastructure at NIPER Mohali. So I thank you all, And thank you for your patient listening. And I will be happy to have the questions from the participants, faculty members, colleagues of this program. Thank you all. Thank you so much.
So participants are requested to ask questions.
Requested to ask questions.
Any question from participants?
Any question from participants?
I think sir has described the topic in very nice and simple way. So most of the participants are already
Sir, I'll decide the topic in
satisfied.
nice and simple way.
Thank you, Jasad sir.
Most of the participants are already
Thank you. Thank you. Yeah. So I would love to have questions, but anyway, either it was they understood all or maybe not understood.
So I would love to have questions, but anyway, either it was they understood all or maybe not understood.
Fine.
Thank you, sir.
Thank you.
Now I request Professor Rajesh Sharma sir to kindly felicitate sir with the certificate.
Yes.
Yeah.
Dr. Ajay, I request you to felicitate Professor Sanjay Jajak, his certificate.
I request you to felicitate Professor Sanjay Jajak, his certificate.
Sir, unmute yourself. Dr. Ajay, unmute yourself.
So we feel pleasure to felicitate you, sir, with the digital certificate.
Dr. Ajay, unmute yourself.
As a token of remembrance. So, kindly accept it, sir.
Thank you so much.
As a token of remembrance. So,
yeah.
So
Kindly accept it, sir. Thank you so much. So
the session is open for question and answer round. If anyone is having any query, please ask.
The session is
available
open
with
for
us.
question and answer round. If anyone is having any questions, sir is available with us.
Sir, I have one question, sir. Sir, I have one question.
Yeah, please, Dr. Ajay, please.
I think there is.
Sir, I have one question, sir. Please. Please, Dr. Ajay.
Sir, how we can decide whether we should go for the preparation of crude extract or phytopharmaceuticals?
Sir, how we can decide whether we should go for the preparation of crude extract or phytopharmaceuticals?
Yeah, Dr. Ajay, I will answer that. There is some problem, like once we speak now, it comes little late. So I will speak slowly, some issue is there. Yeah, actually, when we are talking about phytopharmaceutical product, it is advisable not to take the crude extract for development. So what we are supposed to take a purified extract, because then crude extract is very complex. You will not able to do its quality control. Even the assay, when you go for the let us say analytical method development or for quality control purposes, your assay method will be very complicated. You will not able to do that. So this is another purpose actually. And you know, there is a lot of variation also, okay, in the content and the content of these phytoconstituents in the extracts. So in that way, that's why it is differentiated clearly. It is not an extract. It is the enriched fraction that is prepared, a purified fraction from a crude extract. So here lies the catch actually. And there you need to have now a lot of, you can say, expertise in chromatography basically. And different methods of, you can say, resins and chromatographic materials and equipments you need to have in order to, let us see, get a meaningful enriched fraction that can be converted into a phytopharmaceutical. So this is actually really a challenge that when you really go on the bench, you will realize that.
Sometimes, sir, while doing for phytopharmaceutical product development, a particular phytopharmaceutical may lose their activity, because if you see the cases of crude extract, the extract contains numerous phytopharmaceuticals, numerous constituents, and the activity is because of synergistic effect. So once you go for purification, the purified one may lose or decrease their therapeutic activity.
Okay, but let me see. Yeah, fine. It's another good observation. But let me tell you here what is the catch again, how we can say that. Like I said, no, it's a purified fraction. That doesn't mean it is only the mixture of 4 compounds. First place. Okay, the activity is due to that fraction. We are quantitatively estimating 4, but the fraction what I have seen has more than, let us say, 20 compounds in it already. Different you can say range of concentrations. So that doesn't mean that our extract may you will have around 100 compounds. So there it's not only synergistic effect, there is also antagonistic effect few phytoconstituents have, and there is definitely, it is very complex science to define what is the role of each and every individual component. Like some component may be useful in enhancing the solubility and hence the bioavailability when you give it orally. So those things are also there in this particular extract. But those things actually, if you get the bioactivity, for example, consistent bioactivity with the enriched fraction, it is not only one time observed activity. You have validated it, done it, repeated it twice, thrice, got it done from third party. Then you have the confidence, okay, activity is consistently there. Then we can go for the product development, definitely. But as you say, this type of research is not there. We are just discussing in many forums that, okay, there is a synergistic effect in the extract. If you separate the extract, the activity will be lost. That will depend from case to case basis, extract basis, the type of chemical composition of that extract and the activity you do, in what way you do. So it will depend on that. So in my view, yes, still you have a chance that you go ahead with the let us say phytopharma product, which is not merely a mixture of only 4 compounds. It will be a mixture of certain good number of compounds where 4 you have been pinpointed, and also you have studied that they are responsible for biological activity, because you can isolate them to the activity at the single compound level and then compare the activity in that fraction activity, how it is. Then we can say whether there will be a loss of activity or not when you compare with the whole extract, like crude methanol extract I was talking about, and then the alkaloid enriched fraction. So that is where, after all this, I think these discussions were going on since last 10 years, and then the consensus were made to launch this category of phytopharmaceutical. Okay, so I think this point will be there, but we can address it and solve it without.
Sir, one important concept, one more concept I want to discuss with you. You have discussed various issues in phytopharmaceutical product development, like the collection of the drug material, like the identification and authentication process, the methods of drying, the methods of size reduction, as well as extraction technique, which is starting from traditional method of extraction to novel method of extraction and so many others. They affect the quality of crude extract as well as the phytopharmaceuticals. But why not to use plant tissue culture method as a source of phytopharmaceuticals, because there each and everything is very standardized. You know the progeny of the material, you know the generation of the drug material, and by this way, by the development of plant tissue culture, you can minimize the effect of various exogenous and endogenous factors that affect the quality of the drug material. So in future or in the current time, that's why the concept of plant tissue culture is gaining popularity nowadays, and it looks a very good alternative as well as the source of phytopharmaceutical product development. Why not to think about in that area also, and why not to collaborate with so many agencies who is basically working in the area of PTC?
Yeah, I think it is a very good observation and suggestion, because plant tissue culture as of now we have facility only at the lab scale. Okay, so most of the places, so there is, I don't see hardly anything which is you can say scaled up to the pilot scale. You can do, but that is available. Those facilities, fermentation is very easy with respect to microbes or fungi, but with plants we have a limitation. And what I have seen, I worked in Europe also with the plant. I worked even Hypericum. I can give you example. Hypericum perforatum, very well known St. John's wort extract that is already there commercially used. So there also a lot of cell culture studies were done, and what they found, the profile of the naturally grown plant material versus the material which is grown in the lab in vitro using tissue culture, they were inferior. What they found, they were not as that quality. Their contents were less. Most of them, like we have this the compound called as actually hyperphoric. It content varied a lot actually in the tissue culture material versus the natural material that is grown under you can say controlled condition, cultivated condition. So those type of studies are also there, where tissue culture is one good technique to even elucidate the biosynthetic pathways, how the compounds are made. But towards its commercial aspect, and every time as we expect also that the content of bioactive phytoconstituent. Okay, so that will be enhanced in tissue culture, but that don't happen with every plant species you study. So those are certain limitations with, and the cost will shoot up like anything if you go for plant this biotechnology aspect of plant tissue culture or cell culture. It won't be economically viable for the product development. So this is another issue when you talk about who will buy this pill which is made of this material costing, let us say $100, when we can make it in $10, for example, by this approach of phytopharmaceutical. So those, I think, aspects are there. But yes, academic research and the future wise, this is a good option, like future of the science for the anyway tissue culture is being used since last 60-70 years exhaustively in this agriculture also. We know many food grain these plant materials, they were also grown and studied. The better varieties were come through tissue culture. So those kind of aspects we can also study based on that, but it has then limitation. As we know, genetically modified plants, GM foods, it still is not acceptable. Regulatory issues are there. So those things will come with tissue culture.
Thank you so much.
But otherwise, yeah, nice observation. Can be a future for that.
Yeah. Thank you, sir. I think we all of us, we got enriched by attending your lecture. I think everybody agree with me. So our knowledge gets improved by attending your lectures, sir. And thank you being with us, and you spent your valuable time with we people. Thank you very much, sir.
Thank you so much, and nice to interact with all of you. Yeah, thank you so much.
Thank you, sir, for presenting your excellent work which you and your colleagues are doing, or your students are doing.
Thank you, sir, for presenting your excellent work you and your colleagues are doing, or your students are doing.
Thank you, ma'am. Thank you for your kind words, and please do visit sometime. Okay. Thank you, ma'am. Thank you for your kind words, and please do visit sometime. Okay.
Now over to Bhumika.
Now we'll reconvene after a lunch break.
Now over to Bhumika.
Yes, ma'am. And you all the delegates are requested to kindly come for the webinar on time. It has been observed that some of the delegates are just joining 5 minutes when the lecture is about to finish. So it is being observed, and you will not get the certificate. So you all are requested to kindly join on time and be there for the whole lecture. So we will join back at 2 o'clock after a lunch break. Thank you.
Thank you, everyone.
Okay, thank you, Professor Rajesh Sharma.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, Professor Rajesh Sharma.
Thank you very much, madam, for providing me this very good opportunity to be a part of this program as a chairperson. Thank you much.
Okay, thank you.